So she got up, they sent her up to recovery, and she was putting her clothes on and got lightheaded, sat down, and they thought she was still under the influence of the sedatives. Gave her a few more minutes. She got hypotensive. They started an IV on her to raise her blood pressure back up. You know, give them a bolus of fluids. That way your blood pressure goes up, right? Didn't. It continued to go down. And they transferred her down, this is at St. John's in Tulsa, transferred her down to the emergency room. She gets to the emergency room. The PA is the first person to see her in the emergency room, realizes that she's in trouble, starts another IV, so she's got 2 large bore IVs going, starts on a pressor, dopamine, which is a sympathomimetic, which is going to constrict blood vessels to raise your blood pressure, right? And she just continued to crash, and within an hour, she goes into cardiac arrest. So they start working on her, and this was about 11 a.m. now, 11 a.m. She's in cardiac arrest. There's a thing called, now when somebody bottoms their blood pressure out like that, but they have a rhythm on the monitor. What do we call that? PEA, pulses electrical activity. We know about tension pneumos, we know about cardiac tamponade. The most common cause of PEA is hypovolemia, bleeding out. So they think she's bleeding out somewhere from the colonoscopy. There's a thing called a fast ultrasound, where you take an ultrasound and you do an ultrasound looking for free blood in this area of the peritoneum. You would also, in trauma, look for it in the pericardial sac. You also look for it by the kidneys and in the lungs. Anyway, you're looking for free blood. They knew this woman, she was in PEA. They knew that she was bleeding out somewhere. And she was supposed to be bleeding out here, but there was no free blood. They kept giving her fluids, kept giving her fluids. She kept going into arrest. They kept bringing her back. They started giving her blood. They gave her more blood, more blood, more blood. They finally called the code at 6 p.m. that night. She died. So she never regained consciousness from 10 a.m. when they sent her from the GI lab down to the ER. She died. 62 years old, elective screening colonoscopy. Where was the blood? It was in the folds of this mesentery. And they never saw it with the ultrasound. Because the ultrasound only finds free blood down here. That's why you need to know these folds of the mesentery. The PA, of course, everybody in the hospital was sued. The PA was eventually dropped from the lawsuit after about 3 years because she had just done the intake and immediately saw the lady was in trouble and passed her off to the big ER, not the urgent care fast track. But she wound up not having to settle. This was a multi-million-dollar case that involved free blood in the folds of the mesentery.
Had they known that it was in the fold, could they have done something?
Autopsy.
Okay.
No.
No, could they have done something?
If they before she died.
If they had done so, they called the surgeon down, but the surgeon wouldn't touch her because you can't find the blood.
So there was no way to know that it was in the fold?
Well, that's something that needs to be on your differential. If you know they're bleeding out and there's no blood in what are called the gutters here beside the colon, look in the folds of the mesentery. Turns out when they did the colon, I don't know how it happened. Of course, the plaintiff's attorney is arguing that the colonoscopy hit the spleen and ruptured the splenic artery, and the spleen was a bag of blood. But in from there, it drained, the splenic artery drained out through the folds of the mesentery. And when you get downstairs and pull the spleen up, you'll see that it's floating in the mesentery.
Why can't you see blood not in the peritoneal cavity in an ultrasound? Or is that just where they typically look in a fast
That's where you
ultrasound?
look. Yeah, you probably wouldn't be able to identify blood in here because it's going to look like everything else. It's only when it's in free spaces where it's not supposed to be, will you see it. Okay? All right. That's a little.
Is that the only death-by colonoscopy case ever?
No,
So how do you,
it's like a 1%.
how do you identify that the blood's in the mesentery if the surgeon won't open them up? Until
Well,
they know.
had they known that that's where the bleeding was,
How do they know? Like, how would you?
if they tried to get her to a CAT scan,
Okay.
a CAT scan would have found it,
Okay.
but they couldn't get her to the CAT scan because every time they took her there, she would arrest. So they'd have to get her back and get her, on more pressors. It was just a horrible thing. She went in and out of PEA. I mean, they cracked every rib in her chest, doing chest compressions. I mean, she went into arrest probably 6 times that afternoon before they finally just gave up. All right, so the stomach itself, you want to cut open the stomach. The stomach has rugae inside of it. There are different parts of the stomach. We know about the lesser curvature, the greater curvature. There's a fundus, which is also called the cardia, or cardiac region, for some reason. Maybe because it sits next to, on the other side of the diaphragm, is the heart. This is the cardiac sphincter, the junction between the esophagus and the top of the stomach. Down here you've got the antrum, and then the sphincter, the distal sphincter, is called the pyloric sphincter. That starts the duodenum right there, and the first part of the duodenum is a bulb. It's a dilated area called the duodenal bulb. Most ulcers occur in the duodenum, first part of the duodenum here. A much smaller percentage actually occur. Peptic ulcer disease is really a problem with the duodenum more than it is the stomach. You can see here's the pyloric sphincter here, there's the duodenal bulb, and there is the first part of the duodenum, right there. Here's an ultrasound showing the pyloric sphincter. Of course, if it's hypertrophied in newborns, it feels like a walnut right here. That's the pathognomonic thing. If you feel a walnut right there, and their kids are having projectile vomiting, it's pyloric stenosis. They have to go in there and do these radial cuts in it to loosen it up so formula or breast milk can go on through. Okay? This is the liver. The liver is an unusual organ. It's a very large organ. You'll see in the cadavers, it's impressively large. It has really 2 lobes, a right and a left lobe. This is what it looks like in the cadaver here. This is the right lobe. That's the left lobe on the other side of the falciform ligament. Okay? In this illustration here, what we're looking at is the liver from behind. The liver from behind is more complex. On the front surface, it's smooth. On the back and undersurface, it looks like that. Now, it's an H-shaped arrangement here. This limb of the H is the ligamentum teres, or the falciform ligament, with the ligamentum teres, right here. This is the old obliterated umbilical vein, right, carrying oxygenated blood. When you were a little bitty fetus, you didn't need your liver to decontaminate your blood, which is one of its roles. The placenta does that. So what you're going to do is you're going to bypass the liver through, if this is the artery coming in, you're gonna bypass the liver by another artery going right out the top. In you, that artery going out the top has become ligamentous. It's called the ligamentum venosum. Back when you were an embryo or a fetus, it was called the ductus venosum. So that connected the artery straight into your circulatory system, straight into your inferior vena cava. It bypassed the liver. On the other side of the H is gallbladder. This is the gallbladder, and this is the inferior vena cava. The H is called the porta hepatis. The porta hepatis is this part right here. There are three things that are going to go into porta hepatis. It's the bile duct system, the portal vein, and the hepatic artery. Those three things are going to go in, enter the liver right there. You can see the portal vein has been cut right there. Now, there are two other parts of the liver, two other lobes. They're not really separate lobes. They're called the caudate and the quadrate lobe. Functionally, they're part of the left lobe. So there's one right here, there's one right there. The quadrate sits next to the gallbladder, GQ. Quadrate, caudate. They look like they should belong to the right lobe, but they don't. They belong to the left lobe. This is important when you're trying to resect parts of the liver. Because the vasculature goes into those separate lobes, the right, left, quadrate, and caudate. If we look at the porta hepatis a little bit, now what you want to do on your cadaver today is you want to see where the falciform ligament is there? Cut the left lobe right there, just to the left of the falciform ligament. Remove this part of the left lobe, and that opens up this area right here. It makes it access much better. Okay? Ask me down there and I'll help you. All right, so if you lift up the liver a little bit, this is what you're going to see. Here's the hepatic artery, the common hepatic. It gives off the gastroduodenal, the proper hepatic, the right and left hepatic arteries. The cystic artery comes off of that. There's the gallbladder. There is an illustration over here. Okay? See, it's easy. The artery is right here on the surface. Right beside it is the bile duct. You got a right and a left hepatic duct that form a cystic duct, or a common hepatic duct, I'm sorry. Common hepatic duct joins the cystic duct to form the bile duct, or the common bile duct. This thing is thin. It's really thin. It's like a vein. This is thick. Between the two and deep to the two is a humongous vessel. That's the portal vein. And it's as big as your thumb. It's huge. This contains all the blood coming from the GI tract, containing all the nutrients and garbage you eat. Toxins, everything. This is deoxygenated blood. The liver gets its blood supply through the hepatic artery system. I want you to find this today. The pancreas is interesting. pancreas is, here's the pancreas, like I told you. Shaped a little goofy. This part right here is called the uncinate process. Uncinate process. It should say somewhere on that uncinate process. Uncinate process. Here's the head, the body, and the tail actually sits in the hilum of the spleen. So the pancreas, it runs all the way across your abdomen. Starts over here, runs all the way across. Here's the pylorus of the stomach. Then you have what's called the C-loop of the duodenum. So if we were to draw it out, the stomach, here's the esophagus, the stomach, duodenal bulb, that's the duodenum. This begins the jejunum, right there. The pancreas sits right here. Kind of cool. The other thing, while I'm at it, is this thing right here, this duodenal jejunal junction is attached to the diaphragm by the ligament of Treitz. That's what suspends it.
Since what?
The junction between the duodenum and the jejunum is suspended by this ligamentous fold of tissue attached to the diaphragm, the posterior aspect of the diaphragm, called the ligament of Treitz. So if you want to know you've reached the end of the duodenum, just go to the ligament of Treitz. You can find that in the lab pretty easy. Anyway, because the pancreas and the liver kind of evolved the same, not evolved, they developed the same way off of a duct of the foregut, what happened to the stuff?
Everything turned off.
Everything turned off?
I think that's
You burned it out, you were talking too fast.
couldn't keep up with you.
I guess it shut down. I guess it's been left on all day, right?
No, it's coming on, the light's on.
Okay. Yeah, so this is what happened. The duct system. Here's the C-loop of the duodenum. There's the duct as it developed off of there right there. The diverticulum budded off, grew up, gave rise to the liver, gave rise to the gallbladder, gave rise to the pancreas. So surrounding these ducts are the liver and the pancreas. And notice that they all come together right there. When you open the C-loop of the duodenum, you're going to see that little thing right there. That's called the ampulla of Vater. Around the ampulla of Vater is a muscle tissue called the sphincter of Oddi. I dare anybody to name their dog Sphincter of Oddi. That sounds like a dog's name to me. Oddi. Sphincter of Oddi. Sphincter of Oddi. Right? Okay. Also, you remember how I did this? You know how I did it? Here's my ventral and dorsal pancreatic bud, and they grew together like that.
Yeah.
They each had their own opening into the C-loop of the duodenum. That's why you have two openings. You have an accessory opening, and you have the main opening. One and the other. Okay? That's kind of cool. That's why that's like that. What you need to appreciate, though, is that if you have cancer in the head of the pancreas, it can block these ducts.
Why would pancreatic cancer is so deadly?
What's that?
Isn't pancreatic cancer really deadly? Like it's very.
As it says in this here, the 5-year survival of pancreatic cancer is 1%. That's deadly. The reason is, there's so much room for it to grow that you don't feel it. I mean, why do you detect cancer? Because you can feel it or it's painful. It's not painful and you can't feel it. So it sits there and grows. Same way with ovarian cancer. This happens to be, I think, National Ovarian Cancer Week.
Yeah.
Is that right? Okay. It's the same reason. The 5-year survival, there is no survival for ovarian cancer. Also, you gotta worry about blocking the bile duct here, the common bile duct. When you block the bile duct, bile backs up in the liver and will spill into the blood. In a very elemental sense, let me just say that when you have an increase in, how can I say this without getting too much depth? What's also involved here is bilirubin, a pigmented stuff called bilirubin. It's a breakdown from red blood cells. That's the liver processes it and sends it out through the bile duct system. When that bilirubin starts spilling in your blood because it can't get through here, because cancer in the head of your pancreas, you turn yellow. Your conjunctiva turns yellow, you turn yellow. When you have yellow pigment in your skin, it itches. It's called jaundice. Most of the time, jaundice is caused by a stone here. And cancer in the head of the pancreas, it's painless. Painless jaundice is pancreatic cancer until you prove it otherwise. One other thing about cancer in the head of the pancreas is that if you look right here, tomorrow we'll show you that the superior mesenteric artery and vein pass between the body of the pancreas and the uncinate process. The uncinate process is behind it. So if you've got the uncinate process back there and the body up here, if this thing grows, it can occlude the superior mesenteric artery, making the bowel ischemic. These people complain of these vague abdominal complaints, particularly after eating. Why particularly after eating? Because that's when the blood vessels are going to need to be engorged to digest your food. So that every time they eat, they just get this vague, hard to define abdominal pain. This is one of the things you got to worry about. Now, I know everybody has vague abdominal pain. Don't everybody go run into the clinic saying, hey, I've got pancreatic cancer. No. This is a consistent, every meal, every day thing. Okay. The diaphragm itself is a muscle on the periphery inserting into a central tendon. There are 3 holes in the diaphragm for the inferior vena cava, the aorta, and the esophagus. There's also 2 arches. There's a medial and a lateral arch called arcuate ligaments. These allow for 2 muscles to go through there. One is the psoas, the other is the lateral one is the quadratus lumborum that I mentioned the other day. Psoas goes through the medial, quadratus lumborum goes through the lateral. What goes through these other holes is in this illustration here. You'll see these are called hiatuses. You see it right there at the top, what goes through them. These things, though, go through the muscular diaphragm itself. They don't go through the holes. The splanchnic, the greater lesser least splanchnic nerves, the phrenic nerves, because they go through the diaphragm, they innervate the diaphragm from below, and the sympathetic chains. Lastly, here's your cardiac area. The good thing about the diaphragm is that it forms a natural sphincter that helps keep your gastric contents and gastric acid and the fumes from those gastric acids in your stomach. In some people, though, they have a herniation of the cardia of the stomach above the diaphragm. This is known as a hiatal hernia. In this bottom illustration, in this x-ray, you can see that. Right here is your gastric air bubble. There's an air bubble in the top of the stomach, but you'll notice right there, there's a, you see that margin right, there's the edge of the heart. You see that margin right there? And in that darkened area right there? There's another air bubble right there, like in this illustration here. That is a hiatal hernia. Reflux disease, gastrointestinal reflux disease, or gastroenteric reflux disease, however you want to call it, is when this sphincter is not tight enough. When you lie down, you have stomach contents come up into the bottom of your esophagus, and you feel it as burping. You may be burping a lot. It can even cause cough. Okay? Any questions? See, it's easy. Mars easy too.